When we look at oral health and we relate it specifically to people living with intellectual disability, there is overwhelming evidence that people with intellectual disability have a confirmed higher rate and risk of dental caries, commonly known as tooth decay, higher rate of periodontal disease, most people know it as gum disease. And some studies are actually demonstrating that at least or greater than 80% of people with intellectual disability will experience gum disease. Additionally, people with intellectual disability have a much higher rate of untreated dental disease. And this then leads to an average increase in tooth loss, but also they have lower rates of replacement for these teeth that are lost. So lastly, we look at how this disease is placing such a significant burden on the healthcare system as well, with multiple GP visits and hospital admissions that can be associated with dental issues. But we also need to look with how poor oral health can interfere with daily functions and quality of life. The unmet health needs, the unmet dental disease needs, can often be a marker for other unmet health needs. And we will discuss later the linkages between poor oral health and general health as well. So dental disease comes in many forms. Each of the disease processes listed on this slide are preventable through modifiable controls. So when we look at dental caries, apologies, it's not spelled correctly, that is related to sugar intake and sugar frequency. Periodontal disease is linked to oral hygiene, like toothbrushing. We look at tooth surface loss, and we can break that down into 3 different types. So erosion is associated with foods high in acidic content, or a person who doesn't have a reflux disorder managed well with medication. Attrition is linked to tooth grinding or clenching, and we can see that commonly in people with cerebral palsy, and that can lead to significant tooth surface loss. And then the third one is actually abrasion, and that's where a person maybe has a poor toothbrushing technique. And sometimes because a person with intellectual disability is dependent on others to provide their oral health care measures, we may need to modify that carer's technique to ensure that abrasion doesn't occur. But also we can see this in people with intellectual disability who also have associated obsessive compulsive disorder, where they maybe are a little bit too zealous with their toothbrush. And the last thing we want to consider is trauma. And at the Sydney Dental Hospital, we're very proud to say that we do link in falls prevention in with our oral health care protocols. And we do know that people with intellectual disability can often have an increased risk of falls. And if we fall, particularly on our face, it can cause significant dental trauma. So each of these disease processes has an impact on a person. Significantly, the most likely to occur first is pain, which may lead to infection and then eventually may lead to tooth loss. And here we see a loss of function and aesthetics to that person. What we do know is a loss of function or a loss of ability to chew our food or chew a wide range of foods can lead to issues with nutrition, but also can lead to an increased risk of aspiration for those people with dysphagia. Looking at the aesthetics, we forget that people with intellectual disability also want to have a great smile. Loss of teeth, particularly anteriorly, can cause social isolation, where people will withdraw from social events. And this can lead to anxiety and depression disorders. So there are other additional multifactorial complexities. And I'm just going to look at this quickly. There's lots of words on the screen, and some of which you may know what they mean and some you won't. This list is also only scratching the surface of particular additional complexities that a person with intellectual disability may present to a dental department or clinic. So some of these factors will actually affect the risk of developing disease, but some will affect the mode in which we deliver the dental care, and that may require us to use some modification strategies. Not all of these risks are modifiable, unlike the previous slide where we do have control over most of the issues that we talked about. But we do have to look at ways to explore and work around these factors. So when we look at the dentition, and I'll just go through a few of these definitions. So malocclusion is where our teeth are not meeting correctly. And many people with intellectual disability will demonstrate different types and varieties of malocclusion. They may have mixed dentition, which means they're retaining some of their baby teeth into adulthood. And then those baby teeth will eventually be shed, and there will be spacing and gaps left where the adult successor wasn't present. With microdontia, macrodontia, there's that smaller than usual and larger than usual teeth. And with microdontia, that's quite commonly associated with people with Down syndrome, where they have small teeth and small roots. Then we have hypodontia and polydontia, which is a lower or an increased number of teeth in the mouth, and that can cause all kinds of problems. So if we don't have as many teeth as we need to chew, or we have too many, it can cause problems with hygiene, it can cause problems with function. Some issues are caused by drugs that people take, like drug-induced gingival hyperplasia, which is just an overgrowth of the gingiva. And it's also linked to poor oral hygiene. So if they're both in tandem, that can be quite a severe, and it can be also very aesthetically displeasing. The drugs commonly that cause this condition are anti-epileptics and calcium channel blockers, or some drugs used in immune conditions. We can move on to craniofacial, which looks at skeletal profiles, or things like cleft lip and palate repair. Again, apologies for the spelling mistake. So these can actually go on to affect, particularly with repairs of palate clefts, there can be significant scarring within the mouth, and significant crowding then develops in the adult dentition. This cohort of patients, they have multiple medical and dental visits and multiple surgeries. And we find a high rate of dental phobia, or just near they're absolutely fed up going to the dentist by the time they reach adulthood. So there can be quite a lot of complexities around managing care for this cohort. Looking functionally, we see things like hypersalivation or drooling, and this is more of a personal thing that is embarrassing for the person with intellectual disability, but saliva is incredibly protective, and as dentists we hate to see anybody modify saliva flow. And when we go down a little bit further, we'll look at the condition called xerostomia, which is a dry mouth, and that's linked to drugs that are often used in tandem with intellectual disabilities that dry the saliva and cause lots of dental disease issues. So I'm not going to go through any more, but if anyone has any questions around what some of these may mean, some of the muscle conditions like the dystonia, the dyskinesia, these just affect tone of muscle, the spontaneous movements, different things that present challenges to us as practitioners in trying to deliver care safely. So what can we do to make a positive change for a person with disability? So we need to put the mouth back in the body. And this is not a new concept, but many of us will probably be guilty of not considering oral health when addressing general health matters. We can relate this to people with intellectual disability, but this will also translate really well into every aspect of our work. And I hope that this might be one of the take-home messages for the evening. So we know that people with ID or intellectual disability will often have complex, multiple medical and general health needs. They will potentially have many interactions with you as general practitioners and allied health professionals. And I hope that maybe by the end of the evening, you might start to consider integrating oral health into your usual practice. But why should we integrate? So this slide is a bit busy and I'm not going to read it all out, but what we would say is that the Centre for Disease Control and Prevention will list the 3 most common dental diseases as tooth decay, dental caries, gum disease, periodontal disease, and oral cancer. It also highlights strongly that link between oral health, if it's poor, and then the development of other chronic diseases. So when we look at diet, and I know this is going to be discussed in more detail later on in the presentation, but from a dental perspective, diet is a significant modifiable factor in dental disease management. When control levels are low, there will be a negative overall oral and general health outcome alike. So we can see in the far right corner that diets high in sugar are very well documented to increase risk of developing diabetes, but also to increase a poor control of the disease itself. If we look then at oral hygiene, which affects gum disease or the risk of gum disease, and we know that people with intellectual disability are often dependent on others to provide that care for them. So toothbrushing may not be prioritized, and they may not get the required support that they need from friends, families, carers. In fact, anybody can pick up a toothbrush and help somebody brush their teeth. And we're very happy to help demonstrate, how to do that. But what we need to do is to assure that a person with intellectual disability is supported and does have the assistance, whether that is partial or complete, to brush their teeth as effectively as is possible so that we can maintain a high level of oral hygiene. Now, some of you may wonder why I have put smoking, alcohol, and recreational drugs on this slide. But what we do see is that people with maybe milder intellectual disabilities who are living more independently in our community, they still make some choices in life where they take on very high risk factors. And it can lead to oral cancer, obviously, but they all contribute towards periodontal disease and dental caries. And we know the effects of smoking, alcohol, and recreational drugs on multi-system disease. Now, the one thing I would like to say, and on each of the columns on the right-hand side, I have put mental health into this proportion of systemic potential outcomes. And what we do need to address is the fact that poor oral health, loss of tooth, has a significant effect on mental health. It truly affects a person's ability to socialize, to speak, to function, and to eat. And hence there is a very strong link between oral health and mental health also. So basically, in summary, what we need to do is to strive to minimize these factors. We do need to do it collaboratively. And if we don't, what will occur is that a person will have a very negative impact on their quality of life. But there are more barriers and challenges that people with intellectual disability face. So I have grouped what I feel are the main barriers faced by people with intellectual disability into the following categories. Again, this list is not exhaustive. We as healthcare professionals need to make reasonable adjustments to accommodate and address these barriers. And at Special Care Dentistry and Sydney Dental, COVID pandemic gave us the opportunity to utilize a telehealth platform to help identify, address, and plan for face-to-face appointments. This is something that is now an integral part of our service and will continue to be developed, and has proven to be very effective, efficient, and it's really well received by our patients, their families, and carers. So when we look at communication, how do we know when something is wrong? How can we be inclusive when determining the best course of care? A person with intellectual disability may not be able to verbalize how they are feeling or if they're in pain. We do need to use non-verbal clues like changes in behavior, eating, or sleeping. We do need to modify how we communicate, and we need to ensure that we are minimizing exclusion from their decision-making process. When we look at environment, we're looking at physical access, transportation, parking. We're also looking at the appropriate equipment that we need and clinical spaces. Are they appropriate? Can we lower the lighting? Can we close the blinds? And throughout some of our journeys for our new patients, we have created storyboard pictures to help somebody start their journey from home and then know what to expect when they arrive at the dental hospital. Knowledge is extremely important, the knowledge within our workforce, but also the knowledge within the patient themselves, their carers, families, and the people that support them. So people with intellectual disability need to know how to access services. They need to know how important oral health is and how to prevent any issues with their mouths. And their families and carers and support workers, they need to know all of this too. And the last thing I'm going to put together, so past experiences and competing priorities. So what we find, if somebody has had a negative past experience in their dental life, they tend to avoid dentistry. They become phobic. They tend to put their appointments off, and they only attend when they are experiencing extreme pain. Competing priorities. People with intellectual disability have numerous other multiple appointments, and often dental gets put in the back burner. So the one message I would like everyone to sort of be mindful is that when other things take a priority, or there is a barrier that we may be able to help to overcome, it's really important that we don't lose contact with that person. We need to be mindful and understanding of their difficulties and try to find ways and means for them to overcome those. Lastly, we look at the complexity of care and compromise. Ultimately, people with intellectual disability may have some limitations on the type of dental treatment we can offer, and maybe how we deliver it will also need to be modified. There may be additional risk associated with treatment, And we need to accept that everything may not be possible, and that with modification, even with modification, an element of compromise will be necessary. There is one thing I would like to highlight, and that's the concept of diagnostic overshadowing. I mention it just briefly because I feel that at times we may all be prone to not look fully at the origins of a presenting issue and may simply assume it is related to the intellectual disability or a coexistent mental health issue. So I feel that if a person is exhibiting changes in behavior that could be of dental origin, then we need to rule that out. And we need to do that as part of an overall assessment. These changes could be sleep disturbances, changing to eating patterns. We see people with intellectual disability that become more distressed. They may actually bang their head against a wall. They may bang their hands against their head. They may hold their face. They're definitely more agitated, and they can become more aggressive than usual. And these can be markers for a dental problem. So just to sort of break it up a little bit, we just want to talk about what is special needs dentistry. And Jason did allude to that we do have the Department of Special Care Dentistry in Sydney Dental. So basically the definition tells us that this is the branch of dentistry that is concerned with the oral health care of people with an intellectual disability, medical, physical, or psychiatric conditions that require special methods or techniques to prevent or treat oral health problems, or where such conditions necessitate special dental treatment plans. So I think with what we've talked about before, things may seem a little bleak, but I think what we do need to recognize is that we actually do help, we can help, and I can confirm that we are helping on a daily basis. So Special Care Dentistry is based in Sydney Dental Hospital. We take a comprehensive, patient-centered and holistic approach to oral health care provision for people who are living with a disability. We are recognizing that people living with a disability will hold the same rights for equity and access to health services as any other diverse group. And we do aim to reduce those potential barriers that are experienced by people with disability when they're trying to access oral health services. And we are very fortunate at Special Care to have private enclosed rooms. We have a wide range of transfer equipment and a specialized multifunction room housing our wheelchair and bariatric platform. We strive to break down those barriers and work closely with the person and their families and carers to provide that quality, safe, effective, and equitable care. We aim to create an individual oral health care plan that will be tailored to a person's specific needs and their abilities. But we know that what we do is only a very small part of the bigger picture. Okay, so brief interventional oral health advice. So this can be completed by anybody. It's very simple, and I've broken it down into 4 sort of categories. So all we would ask is that you might recommend a person would try to establish a regular dental routine. The reason we would like them to see us more regularly would be just to offer them that desensitization process if they maybe are oversensitized by the environment. We'd like to identify that dental risk early and then put in place that tailored oral healthcare plan to minimize the risk. And then we also want to treat early. So we want to find those problems, treat, manage, and then maintain. When we look at oral hygiene, we just simply want you to make sure somebody is getting their teeth brushed. We encourage it to be done morning and night, and we do encourage support or assistance. And that, as I say, can be support as in somebody reminds and times, or it can be somebody does hand over hand technique for brushing, or it can be complete assistance where somebody actually brushes for you. We want you to encourage a balanced diet, and I'm sure that's what we're all doing anyway. But we want to avoid those processed, fast or high sugar foods, avoidance of energy drinks and soft drinks, and just promoting safe snacking if possible. And then lastly, we want you to promote fluoride. Fluoride is well documented to prevent tooth decay. Without it, a mouth will decay so fast and to such an extent that it is nearly impossible to reverse. So please, all we ask is to ask somebody to drink a little bit more tap water, which is already fluoridated, and use a fluoride toothpaste. So these are very simple messages. What we generally suggest and what we do is we find one change that we think somebody can make today. So it may be as simple as asking them to drink a couple of extra glasses of water throughout the day from the tap. We're not asking them to change their whole world or turn things upside down, because we all know what crash diets are like. They're not successful, and we will always revert to our older behaviors. So what we would try to do then is build on that one preventative message and maybe add something else, or maybe enhance it as we go along their journey together. So what I would like to talk about is a case that we provided care for in 2020 in the middle of the pandemic. So this is a lovely 24-year-old gentleman with a complex, severe intellectual disability. He has autistic traits, and he does have a very rare identified chromosomal abnormality called the MLS3 gene on the X chromosome. He has suspected dysphagia. He has also suspected obstructive sleep apnea and gastroesophageal reflux disorder. Basically, none of those have been formally diagnosed. These are all assumptions we have made just by knowing this person for a period of time and from talking to the family. So he presented to Sydney Dental, and he's a regular patient. So this gent is on recall with us, and we have provided care for him for a number of years. But he presented with his dad, and dad was reporting a significant change in behavior. He was grabbing at his chest. He was putting his fingers in his mouth and putting his fingers down his throat. He was scratching his face. He was so unsettled, and there was redness in his cheeks at times. And dad was very concerned that this could be an indication there was a dental problem. I wasn't convinced, and the reason I wasn't convinced is because we had provided care under general anesthetic only 2 years ago, and the need of that general anesthetic was quite minimal. So it established what was his oral health risk, and we felt he was quite low risk. So at that point, I started to think, were there unmet health needs that had yet to be identified? We knew we couldn't evaluate the dental condition effectively. Even with the use of oral sedation, we were only allowed a very brief exam. So I couldn't say with my hand on my heart that there wasn't a dental condition that needed some management. I seemed a little more fatigued than usual. And there seemed to be some low social support for the family, who are the primary carers for this lovely young person. Some of our complicating factors were that he was a high-risk patient for a general anesthetic. He had a previous aspiration pneumonia post-GA and was incredibly unwell after that. So we were weighing up those risks and benefits. And there are complex behaviors and resistance to health interventions. So we, on one hand, were trying to avoid a general anesthetic, but on the other hand, knew we weren't going to get the information without a general anesthetic. So at this point, I decided to refer to our local health district STRIDES team, which is the specialist team for intellectual disability in Sydney, just for help with assistance to address the unmet health needs, for behavior support, and for family support. And they are a fantastic team. And together we actually put in place a plan to create a general anesthetic session that would offer full care to include dental review. But also we had gastroenterology, we had ENT, we had ophthalmology, and we were able to take bloods. We were able to provide a full range of medical assessments and complete a dental review under one general anesthetic that only took 2 hours and 40 minutes. It was amazing. And so the next slide is going to be Dr. Alexis Berry's thoughts on the day and what happened and how came together. So Dr. Alexis Berry is the staff specialist for rehabilitation medicine. She works with the specialist team for intellectual disability in Sydney and also works with disability assessment and rehabilitation team for young people based in Sydney Local Health District. So these were her statements. Physical health and dental health for people with disability are closely aligned. Multidisciplinary care provides opportunity for whole of person and family care, as well as support for clinicians who often face very challenging clinical presentations. For many people with intellectual disability and associated healthcare anxiety, dental procedures under general anesthetic provide the only opportunity for examination and procedure, ensuring that potentially treatable conditions are identified. Coordination can be challenging and time-consuming, but ultimately enables opportunity of access to healthcare examination and procedures that the general population are able to routinely access. And she says, it was so reassuring to know that my patient had been properly assessed, bloods were taken, hard to do examinations were performed, so that myself and the family could be confident we were unlikely to be missing anything to explain his behaviors. Now, the outcome of that General Anesthetic multidisciplinary team event was that this young man had severe gastroesophageal reflux disorder. He had Barrett's esophagitis, and he had areas of erosive lesions on his esophagus. He was obviously experiencing severe pain. There was some dental need, but not enough that would have been causing pain. So we were glad that we had performed the procedure. But other things were found in the eyes and the ears. Other deficiencies were found with the blood test. So Dr. Berry was able to then work on actually modifying and treating those other conditions that had been identified through a dental procedure. So it wasn't without sort of barriers, and we definitely had some learning outcomes. So what we noticed was that we really needed very strong coordination of services. And this happened basically by the dental team taking lead, but by the Strides team taking the point of contact with the family, so that the communication was quite streamlined. And then during the multidisciplinary team assessment, we all knew our part to play and our place and our timings. Consent proved quite difficult. There were multiple different procedures, all requiring individual consent forms. We noticed a little bit of staff education may be needed for our day procedure units when we're doing these types of multidisciplinary care. And then we also have the consideration of the local health district boundaries. So Special Care is a New South Wales wide referral service, but within our district, there are boundaries within which they work. So we did have some issues there, and these are things that we're going to work on in the future moving forward. I think the most important thing is to give you the sense of how the family felt. So they just felt that the ability to have so much addressed and looked at in one time was something they had never had carried out before, and they were so incredibly grateful. So this led me to come up with what I call the multidisciplinary dental team equation. So this is where, when you have coordinated service, when you have your professionals, your staff, your workforce that has knowledge, that are able to adapt, that have understanding and resourcefulness, you need to have a willingness and you need to work in a team. When we have that in combination with a person who has intellectual disability that feels supported, understood, valued, and included, reassured, encouraged, and empowered, that will equal holistic, integrated preventive care. And that can be for oral health and for general health. So, refer or not refer is the question. So, what dental services are out there for people with intellectual disability, and when should you choose to refer to a tertiary service like Special Care at Sydney Dental or Westmead Centre for Oral Health? So we feel generally for people with mild to moderate intellectual disability, in the absence of other comorbidities or complexities, it may be quite beneficial to refer them to a local public dental clinic that may be geographically closer to home. So in the bottom right corner here are some links, and they'll be on the slides when you receive them. And that will take you to information around the availability and access to public dental health clinics. So you may be able to give this information to your clients to assist them in accessing dental care. But for those clients in the more moderate, the higher moderate, severe, and profound intellectual disability, referral may be the more appropriate mode, particularly in the presence of complex comorbidities like access requirements, medical complexity, where consent is a consideration, and where people are significantly socially disadvantaged as well. And then we also look at what was their previous dental history. A lot of people will disclose, oh, I only ever have my treatment done under anaesthetic. So we know that this is a cohort of patients that will need some extra support. Somebody who has minimal previous dental experience with an intellectual disability probably needs a gentle desensitizing approach. So that may also be appropriate, where we can support them until hopefully they get to the stage where dental treatment and access to dental treatment becomes routine for them. But anyone who has a disclosed dental, medical, or needle phobia, we're probably best placed to help manage those additional needs. So how would you refer to us? What is our process? So we have an oral health specialist referral form. You can see it in the bottom right corner, and there's the link to how you can find an electronic copy that is easily populated. This referral can be completed by a general dentist, which is private or public, a general medical practitioner, hospital specialist, any allied health professional, disability support workers. We are the only specialist department in Sydney Dental that allows other people to refer. Other specialist departments only take referrals from public dental clinics, but for special needs dentistry, we really recommend that anyone who's involved in your care, who has the knowledge of your condition, your needs, and who knows you best, can make that referral to us for care. And we're very happy to receive it. But as Jason had said, we do and we are subject to waitlist. So how do we try to address those waitlist disparities? So we will always address urgent needs early. So if somebody has an urgent need, so we consider an urgent need to obviously be pain and infection dentally. But if you're noticing a change in eating pattern and someone is losing weight, if somebody's behavior is very altered, then obviously we want to get involved and start to address what may be their dental needs. We want to take a strong preventive approach early, and that's something we do. So while someone is waiting for their full care, they will actually receive preventive care throughout the waiting process. We are strongly using telehealth to identify all the individual needs, and we use that as well to help tailor that treatment plan to assist with whatever each individual's needs may be. We do have access to general anesthetic services, so we're well placed to offer those more advanced care modalities. And we do offer recall services, which I think is vitally important. So we've established what is their dental home, and then we work to reinforce the messages that we're giving. And we can watch and wait, and we can assess how effective all of the measures have been. But most importantly, we are really trying very strongly to offer holistic care. We also have access within this dental hospital to a social work service. We have our resident dietitian, and we have a justice legal partnership. So this supports our clients with maybe some of their more social needs or financial needs as well. Lindy, our dietitian, is a vital part of the special needs dentistry department. And I know that Amanda, who's going to present later on, had spent some time in Sydney Dental on rotation. And I think, and I hope that part of her presentation this evening may include some of the experiences that she had during her time with us in Sydney Dental. So in conclusion, oral health is a balancing act. We do need to identify and establish control over the modifiable factors. This will ensure that we are working together to promote, support, and deliver positive oral health care outcomes to people with intellectual disability. So thank you so much for being here tonight and for listening. I really do hope you will put the mouth back in the body. I hope you pick up the phone or email us if you want advice or support. In doing so, you'll be partnering with us to support, promote positive oral health for people who are living with intellectual disability. Thank you so much.